So I suppose I should start by saying this was a commissioned piece. So we were asked to think about autism in a global sense. So really thinking about, what would be needed across the globe for people with autism. We were a large group of people, many Americans, leading academics, and then 4 people from the UK, some people from Germany, from Scandinavia, from South America. So, really wide range of people from a number of countries, including South Africa, India. And the idea was to pull together the issues that we think are really important across the globe. So certainly, in high income countries, the issues are really around recognizing the diversity of care needed for individuals with autism spectrum disorders. So making sure that individuals at whatever level of difficulty and whatever experience they're having are accessing interventions. And of course, we know that there are people who are not accessing interventions, even within those high income countries. And that's often about equity of access or systems that are not designed in the way that people want to access them. But we were really mindful of the fact that we needed to enhance the case for support for people with autism in low and middle income countries, where it may, in terms of diagnostics and assessment, it may be that there is no access to services that can adequately diagnose and assess these individuals. And so we wanted to focus on what sort of information would be necessary for governments and World Health Organizations to invest in those populations. And of course, if you assess accurately and you diagnose accurately, you can then count numbers, you can then know how many people are in need of the sorts of type of interventions that might be provided. So that was very much a focus of what we were thinking about. That led us to think about what's essential for a diagnosis. So in high income countries, you might be wanting to have a very highly qualified range of professionals who are going to do the diagnosis work. But we were really thinking, is that entirely necessary? How could that sort of assessment be replicated? Or what would be the right way to assess somebody in a country where you're not going to have a range of professionals or you're not going to have a range of measures? So those were the sorts of things we were thinking about in terms of diagnosis and assessment. And then thinking about the epidemiology and really thinking about measurement of numbers so that resources can be allocated to people. So the idea is that, again, this is really about meeting the need in the most efficacious way and a way that is equitable. So there was a lot of thinking about what level of service does everybody need? And a step care approach is really saying that you perhaps would assess a situation and provide some immediate low specialist intervention, say. That's not to say that it shouldn't be evidence-based, and it's not to say that it shouldn't be delivered with, with quality. But it might be that some quite relatively practical, pragmatic approaches to supporting a family would be your first option. And the idea then is that you see how somebody is managing with that, but that you would be vigilant so that if more care is needed, you would step up to the next level of care. So the stepped care approach is really thinking about meeting need in a timely fashion and in a way that's individually tailored to that person, but with levels of specialism or levels of intensity in the way that you provide that. So that's the stepped care approach. It's actually not complicated, but again, the idea is that we need to alert providers of care and funders of care to the fact that there may be there need to be different levels of intervention and different levels of support provided. And we know that people's needs change over time. And there's quite a lot of evidence that we can predict times when people might need more support. So between transitions of school, from going into school, maybe transferring to the next level of provision of school, during adolescence, and then in early adulthood, we know that these are times when somebody might need a higher level of support, which should be accessible to them in a timely way. So involving people with autism and involving people with who have a family member with autism is really essential to help us shape the care that's needed. Those recipients of care are the people who are going to tell us whether it was beneficial or not, and what was needed and how it should be changed. I think it's important to because sometimes even in higher income countries, you get models of delivery of care, you get care pathways, and they are designed in a top-down fashion. And the idea is that these are the resources we've got, and this is how we'll divide them up for the population. But actually, it is so important to find out whether or not that planned care did address the needs of the individual. And what families do tell us is that, they have sometimes complex lives and they need different support at different times. And as I said, even though we have research that tells us there may be these trigger points, we had quite a lot of discussion amongst the author group about things like, a bereavement in the family, or perhaps a house move, moving to another part of the country for work, can be a really, really complex time for a family if they have an individual with autism. So although we think we can anticipate need, we need to find out from people with lived experience what the key things for them are. And often what they will tell us is they need somebody they can speak to readily, fairly easily, and ask for help, and they need help when they need the help. And then it's hard to think about how to design services that can always be responsive to people's needs. And then you asked about lifespan, and I've mentioned that we can anticipate periods of time when people might need a bit more support. Of course, that's always based on the population, not the individual. And there's more thought going into the sort of supports that might be needed as people go into elderly care, and may have additional health needs. And one of the things we talk about is health inequality, with people with autism perhaps not having the same access to healthcare. They may have more difficulty feeling comfortable explaining their illness, and if you have people with low levels of verbal ability, then that can become quite a challenge for people to get the help that they need. In Southeast London, of course, we're talking about a high-income country, not certainly an area with unmet need and with complex social circumstances for some families, but we do have a relatively well-resourced level of service. So I think the key points from the paper there would be, first of all, the acknowledgement that there can be unmet need in locations like South London. But also, I think our view of the need for individualised care, for evidence-based provision, and I think what we're hoping is that providers of services will look at the information in this paper and make judgments about whether or not they're addressing some of these issues in their own locality. But I would remind you, it's a global reach paper primarily. It is a problem being an allied health professional working in research. So initially, when I started my PhD, I wasn't supported really by the university at all. I registered with what was then United Medical and Dental School, which was part of Guy's Hospital, and then worked as a clinician at doing the PhD at the same time. I had some external funding for that, but that was achieved, individually by me. So I would say that going on from that, what's been more helpful is having access to King's and the information resources, the structures. So my affiliation has primarily been with the Institute of Psychiatry, and I've done a lot of collaborating research with people from there. The Institute of Women and Children's Health is relatively new, and so really I would say that I'm very optimistic that we will be able to work with the Institute to enhance careers for academics. I feel that I kind of had to work my own way through it, and I would like to make it easier for subsequent researchers to get the information. I was talking to somebody yesterday who I'm mentoring, and we were talking about all sorts of ways in which we can support individuals doing research to share experience and benefit from a peer group. So it's kind of going to go, I think it's more likely to be beneficial going forward. Well, I suppose that in thinking about autism awareness, I think, we're now in a very interesting time with people with autism, having a powerful voice, increasingly powerful voice in terms of how they think research should be thought about, what it should focus on, how it should be delivered and interpreted. And I think that's really challenging because perspectives may be very different, but actually it is up to us to listen to what's important to people with autism, bearing in mind that they will have a range of different needs and expectations, different voices, and we must make sure that we do listen to all of them. But I think that the Lancet paper is strong on the autism voice, and it is saying, I think perhaps the thing that I'm very pleased that we said was that we believe that we should focus on research that is going to benefit people who are alive with autism now, that we improve the lives of people currently, that we're not thinking about down the line research that's going to be of benefit in 20 or 30 years. We really need to kind of focus on the here and now and what could improve people's lives.